Good evening and welcome to our Psychiatry UK GP webinar on ADHD, and thank you all for joining us. I'm Dr. Jo Farrow. I'm the Medical Director here at Psychiatry UK, and it's my privilege to be opening our webinar this evening and introducing our speakers. Before I do that, I'd just like to share some information with you about Psychiatry UK and what we do. We are the largest digital psychiatry service in the UK. We were founded back in 2012, and then in 2019, we were awarded one of the first right to choose contracts with the NHS to deliver adult ADHD assessments. We are the only at-scale national consultant-led service with over 400 GMC-registered consultant psychiatrists and 200 specialist prescribers working with us. We deliver over 10,000 assessments a month for the NHS across our adult ADHD and adult autism services, with around 7,500 of those being in adult ADHD. We are regulated by the CQC. Our dedication and commitment to improving quality and safety sets us apart. Back in January, we were inspected by the CQC and rated good in all areas, with no actions for improvement. We follow NICE guidelines and best practice across all of our clinical services. Every month, over 96% of our patients that we've seen for an assessment rate us as good or very good. We're a digital and data-driven organisation, and we provide patients with a highly accessible and seamless service. We use intelligent AI to assist our clinicians to improve the quality, safety and efficiency for our patients. Across Psychiatry UK, we recognise the pressures faced by our colleagues in primary care and across the system, and we seek to work in collaboration to support our patients to reduce the burden on our primary care colleagues. For example, we've improved our processes to ensure that all our reports following an assessment are written and sent back to our GPs who referred us the patients within 5 days. I'm now delighted to introduce our two speakers this evening. Dr. Sam Spavin is our ADHD clinical lead and a consultant psychiatrist and expert in ADHD. She had extensive experience in the NHS as a consultant before moving to work with us here in Psychiatry UK. She clinically leads the ADHD service, which is our largest service here at Psychiatry UK. She works collaboratively with our consultants and other colleagues to improve our services, keeping the patient experience at the centre of all that she does. And our second speaker this evening is Sarah Moat. She is our Senior Clinical Treatment Coordinator here at Psychiatry UK. She's here this evening as an expert by experience, and she's going to be sharing with us her very personal experience of living with ADHD and the positive impact that an ADHD assessment and treatment has had on her. After their presentations, we have time for a Q&A session, which we invite you all to participate in. I'd just like to share some guidance to help you all get the most out of the session this evening. We've muted your microphones to reduce the background noise. Please use the Q&A or chat function to ask questions or share reflections during the sessions. Raise your hand via the Teams feature if you'd like to contribute verbally. Please be respectful and considerate of all participants and speakers. Please avoid sharing any patient identifiable information during the discussion. And let us know if you experience any technical issues by posting in the chat. Lastly, before I hand over to Sam to start the presentations, let me please introduce to you Sharif, who is our Senior Primary Care Relationship Manager, who'd like to say a few words.
Thank you and good evening, everyone. My name is Sharif, and as you heard, I'm the new Primary Care Relationship Manager for Psychiatry UK. Just for a bit of background about myself, I've worked 8 years in primary care working as a GP practice manager. I've worked directly supporting practices, PCNs and GP federations. And before that, I was involved with GP out of hours and NHS 111 services in London. I completely understand the pressures and complexities you face every day. And I know how hard things must be right now, especially as it's in the middle of the flu season. And my role is to be a direct link between yourselves and Psychiatry UK. I'll be engaging with primary care professionals like you regularly because I want to hear what's working well and what isn't. And I want to make a difference to you. Your insights are really important to me, so please know that my door is always open. I'll be dropping my contact details in the chat, so please reach out if you'd like to have a follow-up call with me. And now, Dr. Sam Spavin, thank you.
Hi everyone, I'm going to talk to you in more detail about ADHD and hopefully some areas that you will be interested in hearing more about. Over the next half an hour or so, I'll talk to you about diagnosis and prevalence of ADHD, covering differential diagnoses and comorbidities. I'm going to look into more specific topics related to ADHD, and then really the impact of not treating ADHD and the benefit of treating ADHD. I'll go through the medical treatments for ADHD and then talk in a bit more detail about the GP journey. So I'm sure we're all aware that ADHD is a neurodevelopmental disorder. It is highly heritable. We know commonly when we assess people for ADHD, we will see parents who've got the diagnosis, children who've got the diagnosis, siblings, cousins. It's a condition where there are a group of symptoms, mainly under inattention and hyperactivity and impulsivity. It's quite interesting because actually ADHD can look different for each individual. There's about 18 symptoms altogether, and to get the diagnosis you've either got to have 5 or more symptoms of inattention or 5 or more symptoms of hyperactivity and impulsivity, or a mixture of both. Symptoms of inattention can look like being easily distracted, difficulty finishing tasks, making careless mistakes, losing things. Symptoms of hyperactivity can include restlessness, fidgeting, excessive talking, interrupting people, making impulsive decisions. We know in order to get a diagnosis of ADHD, you have to be able to demonstrate symptoms of ADHD before the age of 12 years old. It is a lifelong condition. It's estimated at the moment that about 5% of children around the world have ADHD, and 3 to 4% of adults have ADHD. There's maybe to be a slight drop in the adult prevalence because of the change of environment, and also the ability, people have found coping strategies to manage their ADHD, so it's no longer an impairment and more ADHD traits. We also know that people with ADHD are more likely to experience other mental health conditions. When we're diagnosing ADHD, it is a list of difficulties and symptoms, but those symptoms can often overlap with other conditions and be similar to other conditions. So it's really important that we do a detailed assessment, really looking into those symptoms and looking at what the root cause of those problems are in order to get an accurate diagnosis. So you can see that there's there's both mental health and physical health conditions that can mimic ADHD, including things like autism, emotionally unstable personality disorders, depression, anxiety, complex PTSD. Physically, you've got things like hypothyroidism and hyperthyroidism. So we should be considering all of these when we're making a diagnosis. We also know that ADHD is associated with a high number of comorbidities. I think there's quite a lot of different reasons for that. There's the neurobiology, the genetics, there's environmental factors, there's factors including trauma. We know that there is a high comorbidity of depression, anxiety, substance misuse, which I'll talk to you about in a minute, as well as various eating disorders. Binge eating disorder is highly associated with ADHD, and it might be interesting to know that in America, lisdexamfetamine is licensed not only for ADHD but binge eating disorder as well. Just to talk a bit more about substance misuse, about 40% of patients with ADHD struggle with substance misuse. It's thought in many cases that it is a way of self-medicating. We know that a high proportion of adolescents with ADHD are affected by substance misuse, and vice versa. There's a high proportion of people with substance misuse who are affected by ADHD. We know that treating ADHD can reduce or delay the onset of substance use disorder. There have been large studies that have looked at the support of medication management, and it is considered managing ADHD is considered being protective against substance misuse. Just thought I'd talk about a few specific areas of ADHD that might be of interest to the GPs. There's something called ADHD. This is when you have both ADHD and autism. Autistica, which is a very large research charity for autism, believes that 3 in 10 autistic adults also have ADHD. And this can be one of the most problematic groups where they really experience significant problems in all domains of life. The combination of conditions mean that they have quite a unique profile. And each condition exacerbates the symptoms of the other condition. So it's a bit like anarchy. Another area to be aware of is the gender variation in ADHD. At the moment, the research suggests that boys and men are more likely to be diagnosed than girls and women, with a ratio of around 3 to 1. We don't know how many women are undiagnosed, but I think there are probably lots of women out there who just don't have a diagnosis of ADHD. And that's often due to the fact that they have a different symptom profile, that a lot of their symptoms and difficulties are internalized, and they're more include psychological distress, more affective mood components, whereas perhaps the boys and the men, present more as the naughty child in the earlier ages, and have more externalized factors that bring their ADHD to other people's attention. Thought I'd talk a bit more about ADHD and menopause. This is becoming quite a significant topic, and I'm sure in your GP clinics you will hear a lot about this. We know that there is a large subgroup of women who come to Psychiatry UK and elsewhere for assessment and diagnosis of ADHD in their late 30s, 40s, up into their 60s. And we find really that the perimenopause period can really intensify the symptoms of ADHD, or that's when the difficulties can really emerge. We believe that this is in part at least due to the decline in estrogen, which then affects the dopamine regulation. worsening cognitive and emotional control. And I think as a GP, you've got a key role in recognising that group of patients. It's also important to recognise that there are a lot of similarities in the symptoms of both ADHD and menopause. For example, ADHD symptoms would include inattention, impulsivity, emotional dysregulation, whereas you've got the menopausal symptoms, which can include brain fog, mood swings, irritability. So the symptoms can both mask each other and mimic each other. So it's again really important to think about the timeline of people's journeys, of people's difficulties, and really get an idea of what's going on in their clinical picture at the time. For those who are being affected by the perimenopausal period, ADHD medication is still effective. It's still a treatment that should be considered where appropriate. Equally, it's really important to recognise the role of hormone replacement therapy. For some, obviously, it'll be starting the treatment. Other people, it'll be optimising their HRT. In some cases, by treating them with HRT, you won't actually need to otherwise medically manage their ADHD. It's also important, obviously, to think of the holistic approach in managing ADHD, which includes behavioural and lifestyle changes, which I'm not really going to be discussing today. I think it's really helpful to be aware of the impact of ADHD. And I'm sure you're all aware that there has been 2 reports that have come out recently, reports on the Independent ADHD Task Force. And believe it or not, it's actually quite an interesting read. So it is worth having a look at. It estimates that not treating ADHD costs the economy £17 billion. It's thought to be related to lots and lots of different areas, less tax contributions, more reliance on state, higher costs to healthcare, social care, criminal justice system. I'm not sure if you're all aware of the term NEET, but that is those not in education, employment or training. And it's known that in the young people who are in that group, 20 to 34% are likely to have ADHD, and the majority of those will be undiagnosed. So again, it really demonstrates that a lot of these costs are avoidable, and it highlights the importance of assessing and treating ADHD. And I am going to go into that a bit more, perhaps be a bit repetitive about it. So again, there is a cost of not treating ADHD. There is a significant burden on the NHS and healthcare. That's due to the higher mental health needs that this group of patients have, especially those undiagnosed. And also, this group also present in A&E through accidents and injuries. There's a big cost to the educational system due to school exclusions. It has a significant impact in students' education and employment experience. In the prisons, at least 25% of prisoners have ADHD, and their difficulties often contribute to crime and reoffending rates. There's also that significant strain on social services due to family breakdowns, reliance on welfare, housing, substance misuse problems. So again, just to make it clear why it's important to treat ADHD. Having ADHD has a significant impact on academic and work life. It really has an impact on poor focus, difficulty completing tasks, and that has a negative impact in your performance. You've got an increased risk of accidents due to your impulsivity, inattentiveness. It has a significant impact on your mental health with high rates of depression, anxiety, and substance use. And it can affect all relationships. So both relationships at home, in your own social network, and those at work. If you're looking at return on investment, each pound you invest in ADHD treatment can provide £16 in return over 10 years. So treatment can save nearly 493 million over 3 years and 1.92 billion over a decade. Just a minute, something's... So now I'm going to focus a bit more on medication. So again, I'm not going to go through the NICE guidelines. I'm not going to go into detail about the holistic management of ADHD. Those are really important areas. They're important. The holistic side of management of ADHD can be used without medication, and equally is more helpful when used with medication. So it is important. I'm just not going to discuss it today. We use 2 types of treatment to manage ADHD. We have the stimulant group and the non-stimulant group. Stimulants are the first line in managing ADHD. There's 2 types of stimulants. There's methylphenidate, which has got lots of different brand names. You've got Concerta, Zagotin, Delmasart, many more. Lisdexamfetamine is commonly known as Elvans. They both work the same way. They work by increasing the dopamine in your brain, which affects your reward center, which should improve your ability to concentrate, complete tasks, and can improve emotional dysregulation. The benefit of it is it works quickly, and it has a really high response rate of around 70 to 80%. And that's kind of unheard of, certainly in mental health, and I'm sure in other fields of medicine. Equally, it means that 20 to 30% of people don't respond to medication or can't tolerate it. So when that happens, we then consider the non-stimulant group of medications, and that's called atomoxetine. That is a serotonin noradrenaline reuptake inhibitor. It works like an antidepressant. From what I understand and what my peers tell me, they don't think it's a great antidepressant. However, it is good at managing ADHD, and its response rate is around 50 to 60%. So still really, really good and worth trying. In Psychiatry UK, when we start treatments, we do a titration of both stimulants and non-stimulants. The titration usually takes 12 to 14 weeks. That's then followed by what's called an end of titration review. And at this point, if we think treatment should be continued, we then complete a shared care agreement and send that to the GP. And I'll talk a bit more about that in a minute. Of course, when we're considering medications, there are always side effects. Interestingly, both groups of medications have a similar side effect profile. Insomnia is a problem. It's a problem with ADHD, and it's a problem when ADHD treatment started. So it's something that ADHD medication can make worse. Equally, in some patients, they find it helpful for their sleep. But what we do encourage people to do is take it first thing in the morning. So by the time people are going to bed, it's most likely to be, the majority of it's going to be out of the system. It can have an impact on your appetite. Equally, some patients find they eat a bit more because actually they have more structure, they're less forgetful, they're able to plan for their meals. Headaches can be quite common, especially at first and when changing the dose. One thing that we find helpful is making sure people drink enough fluids. Dry mouth is a problem, but it's relatively easily fixed normally by looking at hydration. An area that we're particularly interested in, I'm sure GPs are, is medication can increase your heart rate and your blood pressure. Some research is coming out now that actually it's not thought to have such an effect as what we used to think about it. But that's one of the reasons why we always look at people's baseline blood pressure and pulse. We then monitor it fortnightly throughout their titration with us. And then when they continue their treatment, it's monitored every 6 months. People can also find that the medication affects their mental health. It's not uncommon, certainly when you're starting off treatment, that someone can feel a bit more agitated or irritable. It can also be a dose effect. So obviously we don't know what doses people need. Sometimes we're going to go too high and that person could, for example, experience more agitation, irritability, palpitations. And we would just look at that dose and then just reduce it to the dose when they didn't have any side effects, but they were still having clinical effect. Atomoxetine has got very, very similar side effects, including the appetite changes, sleep disturbance, but it could also cause drowsiness as well as insomnia. It can also have an impact on your mental health. And I think one thing that we do tell people about is there is that small risk of having suicidal ideation. So it's worth informing people about that, even though it's still a relatively unlikely event. It can still affect your blood pressure and pulse rate. So we still monitor that throughout the titration period and throughout the time they take the medication. It can affect your liver. So it's worth knowing and thinking about that, and it can cause some urinary symptoms. Thought it'd be useful to look at the patient journey after you have done the referral. So the majority of patients at the moment that we see have been referred via right to choose. We have got a private practice at the moment. It's a pilot, but we're really pleased with how that's going. So we're hoping in the near future that's going to expand so that people can be referred to us privately. When the referral's been accepted, the patient will be asked to do some forms. These are relatively easy forms, although I think for people with ADHD, it can be a bit tricky at times with some procrastination. The forms include the ASRS report scale, a self-report where they describe their symptoms, an informant report, and this is usually done by somebody who has known them since childhood. And we also get them to do a health form as well. The patient's then provided with an appointment link where they can book their appointment with a consultant psychiatrist. The assessment is then online, so it is virtual, and it's really worth highlighting that to patients. It usually takes around 50 to 60 minutes. It can take longer, and sometimes we offer a follow-up appointment in order to complete the assessment. We're usually then able to say if a patient does or does not have ADHD. Even assuming they've got a diagnosis or not, we would then provide them with holistic information on ADHD or ways to manage ADHD traits. We would talk to them about medication. If medication was appropriate and they want medication, we would then refer them to our titration team. During this whole process, we work closely with our partners, so we work closely with GPs, community mental health teams, perinatal mental health teams, and the physical teams like cardiology, neurology. It's probably helpful for you to know what is useful for us, for you to include in your ADHD referral. We do like to know, have a brief summary of a psychiatric history. If a patient is known to a mental health team or has been known, any correspondence from them is really helpful. If they've been diagnosed in the past with ADHD, that would be really good to know. And again, any reports that you have would be good to be sent with the referral. And if the patient's on medication, it'd be useful to know what that is and what dose. Equally, we like to know if the patient's on any form of medication, both physical and mental health related, and if there's any plans to change those medications. And it's good to know about their cardiac health, as that then helps us decide if medication is appropriate, and if so, which medication. Again, just going into a little bit of detail about the shared care agreement. This happens after an end of titration review. We then complete a shared care agreement, and that is sent to the GP. We then wait for your approval. That approval can come in a few ways. It can be done by just simply signing and returning the shared care agreement for us, or we can receive approval via letter or email. If we don't hear from the GP after 28 days, we will assume it is a declined shared care agreement. When we talk about shared care agreements, we're asking you really to continue to prescribe the patient's ADHD medication. We would want you to continue to inform us of any relevant medical history that changes during the course of people's treatment, any concerns about their mental health, and anything that would signify other deviations from prescribing. We'd be asking you to monitor their physical health, which usually looks like 6 monthly blood pressure, pulse, weight checks. Thought it'd be helpful to end with how to make GP clinics ADHD friendly. Just a reminder that people with ADHD can be highly stimulated. They can be very distracted. They can be emotionally dysregulated at times. So creating a calm, organised environment can be really helpful. So minimising distractions, soothing colours, quiet waiting areas, clear signage is very helpful. Having online booking for appointments, reminders, text and calls are very helpful. Sometimes having longer slots available to focus discussions. Fidget tools can be really useful. Shorter waiting times can be helpful. Same-day bookings, walk-in options are positive. And also training your staff, making them aware of ADHD and the need for patience and clear communication. So in terms of hopefully what you will take away from today, we've talked about what ADHD is, the importance to think about differential diagnoses and comorbidities. We've talked about some specific areas of ADHD, including gender difference, menopause and ADHD. We talked about the importance of assessing and diagnosing ADHD and the impact of treating this group of patients. I've discussed treatment and how we work with our partners. So I'd now like to have the opportunity to introduce you to my colleague. Her name is Sarah Mowat. She is our Senior Clinical Treatment Coordinator in our clinical ADHD titration team. She has a mouthful of a job description. She is a patient who has ADHD, and she's going to talk to you today about her experience.
Thank you, Dr. Spavin. Good evening, everyone. It's an absolute pleasure to share this space with you this evening, and I'd like to take you through my lived experience journey with ADHD. So, growing up without a diagnosis was very challenging. I was aware that I was experiencing life differently to others, but I was too young to understand why that might be. As you can see, little Sarah in the photo grew up with mum, dad, and you can't see him yet, but a little brother. I struggled with sleep and restlessness from a very young age, and looking back at my baby book, as you can see, gave me a bit of a giggle because nothing's changed. The sleep times are not often, and the play times are probably not as often now as an adult, but still very often. Next slide, please. Thank you. Mum and dad divorced at the age of 7, and I'd always been very socially awkward as a child. And when my brother was born, I pretty much velcroed myself to him. At school, I came across as very shy, spending my playtime lining up my marbles on a drain or looking through my football stickers. Friendship wasn't something that came easily to me, and moving into junior school brought increasing challenges. My self-esteem and confidence were very low, and I became the ultimate people pleaser, putting other people's needs before mine, and that meant my voice was often suppressed. My first memory of being aware something was different came at the age of around 6 or 7, and the class was given a piece of black craft paper and some coloured pastels, and we were asked to do something with it, but I couldn't remember what that something was. I felt scared and confused. Why is everyone getting on with this? Why hasn't it gone into my brain? I remembered nothing, and I felt fear in speaking up, so I just sat there in silence. As I moved into secondary school, I felt a lot more pressure. I struggled to stay alert in class, and I was often told off for looking out the window and not paying attention. But the truth was, I was just paying attention to anything and everything, including the very relaxing trance that the swaying trees provided, when I now know I was overstimulated. Memories of late nights spent in tears with my dad because I'd either forgotten my homework or I couldn't translate what the homework was asking of me. And I'd left it until the very last minute again. But every day I'd turn up, homework in my hand, like a good student, and no one was any the wiser. My behaviour was very good. I never got detention in school, but I was absolutely exhausted, and my lack of confidence was crippling. I avoided volunteering for anything, putting my hand up. I just kind of tried to disappear into the background, and that meant my self-esteem and my worth were quite severely impacted. As you can see here, I have myself, my dad and my brother. I noticed some of this kind of same and similar struggles in their lives. We all got labelled as very chatty people, lots of energy, great fun to be around, but we got shunned a lot for our enthusiasm, our passion, and comments would often be made about us not really being interested in what people have to say due to struggling following conversations and sometimes finishing other people's sentences. We were trying so hard to just fit in, and so masking played a big part for all of us in our lives. For decades, I went from GP to GP asking for help, and I was living in fight or flight mode 24/7. I suffered with chronic insomnia from a very young age, often staying up late at night with my dad, who didn't realise at the time also had ADHD. And I also had very bendy joints, a lot of frequent headaches, just general kind of all over body pain. And I was always struggling with my weight. Following a fall a few years ago due to the hypermobility, I was also diagnosed with a rare condition called complex regional pain syndrome, which had an enormous impact on my life. Life was just miserable, and my employment was really being badly affected for lots of different reasons. No antidepressants or anti-anxiety medication had any effect, and one GP even suggested I was faking it. I was then referred to a psychiatrist and then misdiagnosed with, at the time, was called borderline personality disorder. I watched a webinar led by an ADHD consultant who had a special interest in women with ADHD. And whilst I was watching that, the penny just dropped, and I was in tears. All the little pieces of that puzzle just suddenly came together, and it was quite overwhelming. And I reached out to my partner afterwards and said, I can't do this anymore. I just can't cope with life. And it took all the mental energy that I had in me to just reach out to my GP and book an appointment and just talk to them about getting a referral for assessment through Right to Choose. I genuinely could not have asked for a better consultation. My GP was so warm. She listened through all my over explaining, all my oversharing, and she just smiled and apologized. And she comforted me in saying, I'm so sorry this was never picked up. I do believe you, and it's clear that we need to get you some support. And the weight that lifted was absolutely incredible. And there was no fight. I didn't have to fight my case or convince somebody, and it just made things so much easier for me. And then at the age of 38, I had my assessment and was diagnosed. Slide, please. Thank you. And I sat there for a while reflecting on what had just happened in my assessment. It was really hard at first because for so many years I'd convinced myself I'd probably made this all up in my head, and a psychiatrist would probably just put it down to anxiety and I'd look like an idiot. I felt confusion. I felt, how could this have been missed by so many people, by my parents, by my school, by pretty much everyone? It joined up so many dots, the time blindness that would usually involve getting told off for boiling saucepans dry, forgotten cups of tea found in the microwave when I'd gone to reheat another cup of tea, the constant anxiety, the daily struggle with organising life and sort of personal and professional. I'd branded myself highly sensitive and stupid for many, many years. And after having some time to process all that roller coaster of emotions, it started to gently sink in. I'm actually not stupid, and I'm not lazy, and I'm not stuck anymore. And this very much felt like a turning point in life where I could gather all of that wonderful information that my psychiatrist had provided me with and do something great with it. I have a plan, so it's time to stop beating myself up and figure out how to move forward in life. I felt so empowered, and in my assessment, the clinician discussed options with me about treatment. And because my ADHD was having such a significantly challenging impact on my life, I did choose to be referred for titration with ADHD stimulants. And this is where my life completely changed. So my titration prescriber was absolutely amazing. She supported me on a one-to-one basis, and we found a medication that just rocketed my well-being and quality of life. And I remember laying in bed one night thinking, it's so quiet. Is this what my brain is supposed to feel like? And I just genuinely cried with relief. I couldn't believe that this was how things might be for other people. And my GP then took on my shared care once I'd finished my titration, and they continue to support me really, really well. And since my diagnosis and treatment, I've started to learn to drive, which is exciting and scary. I got promoted. My relationships have improved significantly, and I was able to finally come off of mood regulators when I'd been misdiagnosed with emotionally unstable personality disorder. Something that I didn't expect was my fibromyalgia also improved as well. So that kind of overall body pain became less. And I just kind of feel like I'm thriving now, not just in survival mode constantly. And I can take off that mask more easily and feel much more connected to society now that I know what I'm dealing with. This diagnosis also made my 75-year-old dad and my younger brother feel confident to also seek an assessment, and they both now have a diagnosis as well. And the GP surgery knows us all very well and just supported us as a family. And I couldn't have honestly asked for any more. Some people may think 75 is too old to get a diagnosis and think, why, if you've coped all this time without one, why do you need it? But my dad wasn't coping, and he had no answers. And it allowed him to let go of decades of self-blame, shake off all the bullying, for being different in boarding school, all the negative comments that he'd received during his years of employment, really kind of putting him down. And it also really opened him up to ask for help when he was caring for his late partner with dementia. It gave him so much inner peace and the kind of start of self-love for the first time. Since then, my wider family, my cousin has received a diagnosis of Ehlers-Danlos syndrome after years and years of suffering because she mentioned neurodivergent family members. And since then, she received an autism and ADHD diagnosis too. My diagnosis has also provided a unique perspective as a patient and professional in how we can best support our patients, including our processes and the way in which we communicate. Thank you all so much for taking time to hear my lived experience story, and I'll leave you in the very capable hands of Beverly for a Q&A session.
Thanks, Sarah. So we're now at the Q&A section of the webinar. As a reminder, please avoid sharing any patient identifiable information. And if you would like to ask a question to our panel, just let us know and we can unmute you. That's no problem at all. We do have an advanced question that was sent in before the webinar started, so I'm going to pose this to the panel now. So this comes from a practice pharmacist who said that patients are querying being prescribed SSRIs for low mood anxiety with a dual diagnosis of ADHD, suggesting we should instead favour venlafaxine for SSRIs for this patient group. Is there any evidence around this we are unaware of?
I think at the moment, there's two stories to it, isn't there? So firstly, we know that anxiety and depression are common in people who have ADHD. So at times that needs to be treated, and an SSRI will always be the first line treatment. We also know that many people with neurodiversity don't respond that well to antidepressants. There's some evidence showing that people do respond a bit better to the SNRI group, like venlafaxine. Equally, what we also know is that when people's ADHD is managed, quite a large portion of people are less likely to experience mood disorders. They'll have improved emotional dysregulation, hopefully feel less anxious, so they may not need other psychotropic medication.
Brilliant, thank you. Thanks for that, Sam. We've got a couple of questions around autism and ADHD. So one was, do you assess for autism at the same time and screen for comorbids? And also, can you explain a bit more about the difference in autism and ADHD?
So we will accept joint requests for assessments. They're not done in the same appointment. I think that would probably be far too long appointment and too stressful for people who've got a neurodiversity. We have many clinicians who do both ADHD and autism assessments. So there is an opportunity, although it's certainly not promised, that the same clinician could potentially do the assessment for both. I'm not going to be able to go much detail about autism because I'm not an assessor in it. I think the symptoms can be similar, but again, it's looking at the root cause. So having ADHD doesn't mean you have necessarily reduced concentration and attention. It often means that you're concentrating on focusing on the things that are of interest with you. And equally, people with autism can hyperfocus on their specific interests. So you can have the same symptom, but the root cause of that is different. I'm not sure if anybody else wants to give a bit more detail about the differences in ASD and ADHD. I suspect the reality is it's a whole different conversation, and we could probably do our next talk on that.
New webinar. Your waiting list still seem long compared to other new providers. Are they coming down?
I'll come in on that one. So we've done a lot of work over the last year, growing our clinical capacity, getting increasing number of consultant psychiatrists working with us in Psychiatry UK. And our waiting list for ADHD assessments is now around 6 to 9 months, whereas previously it was around 12 months, which we considered was longer than we'd like it to be. However, if we have patients that are referred to us that are particularly complex or high risk, then those patients will be offered an assessment sooner than that. We are able to prioritise those. And also when a patient is referred to us, how soon they're seen for the assessment, there is some reliance on the patient to engage with the referral process, to complete their pre-assessment forms. And now that we're moving into the world of ICBs, having to carefully manage their budgets, obviously some patients, when they will receive an assessment, does depend on the funding stream from the ICBs, may affect that as well for some groups of patients.
Great, thanks, Jo. Sorry, was you going to say something? Yeah. No. Okay. So there's another question here. I'm also increasingly seeing older patients, especially women in their 50s and 60s. Is there a point where you wouldn't recommend referral?
No, we don't have an upper age range, and I think, like Sarah so eloquently said, no matter what your age, you still can have impairments. Having a diagnosis is still really helpful. We know that above the age of 60, we always do baseline ECGs, and perhaps the older you get, we're aware that people may be more likely to suffer from other physical health problems, and there may then be discussion about the risks and benefits of medication. However, always going to be available, holistic treatments, lifestyle advice, work adjustments, because people are working till a lot later. So a diagnosis can always be helpful.
Brilliant, thanks, Sam. Of the patients referred into Psychiatry UK, what percentage get a diagnosis of ADHD?
So in our ADHD service, we do track the data for this, and it is about 85% of patients that are assessed for ADHD receive a diagnosis of ADHD. And I think that is to be expected, because these people have been screened and triaged in primary care. They've completed the ASRS form that the GPs have looked at. So yeah, it is around 85%.
Thank you. Do we provide shadowing programs for GPs with an interest in neurodiversity?
No, is the simple answer. No, we don't. We are looking at opening our services to more GPs who are interested in managing ADHD. We're looking at potentially, employing GPs who might be interested in prescribing for our patient group. That we have GPs in our service. We have the most amazing physical health liaison lead who is a GP. We're looking to employ somebody who will work alongside him as well. So, we do employ GPs, but at the moment we wouldn't be doing shadowing.
Brilliant, thanks, Sam. I believe there was a question around share care agreements, and I think, Sharif, you've been in contact with them, and that's all, you're going to be talking to each other. Brilliant. So we've got quite a few questions, so I'm going to go on to the next one. Are you able to talk about the long-term side effects of being on medication? There's a worry about worsening health, mental health, risk of psychosis and dependency.
Trying to think how to answer this. I think that adult ADHD, perhaps in the research world, is still relatively new. I mean, I think we're looking at 10, 20 years. So perhaps there's not that much detail for the long-term impact of our medication. if any of the panel want to say differently, please do interrupt me, by the way. I think really what is apparent is the gains, the benefits of treating. There will always be people who have side effects to the medication. We will always monitor, and at times it's really appropriate to stop treatment. There are people who during the course of their time on treatment are going to develop other physical health problems, mental health problems where treatment may not be appropriate, and we would stop it. In terms, there isn't really a history of dependence on medication. There can be some tolerance that can develop. We don't really know how long our medications work for individuals, and I think there's quite a huge variety of effects. There's some people who we know are taking medication 10, 20 years down the line and are still getting really good effect. There's other people who will take it after a year or so, and they have less effect from their treatment. We always talk about having treatment breaks. People don't need, once they're titrated, once they're on a stable dose, people don't necessarily need to take the medication every day. So for example, we might tell people to, if they just work Monday to Fridays, to not have it at the weekend if they don't need it, or if they're going on holiday for 2 weeks, they can have a treatment break. That's thought to reduce the risk of tolerance developing. As for any other long-term health disadvantages, I'm not aware of any that we know about.
Brilliant. Thanks, Sam. Right, another one here. Do you find people over the years need higher and higher doses? How is it managed? Because I see a lot of adults who complain that their doses don't last as long. And I think maybe attached to that is there an upper limit for starting medication?
So there isn't an upper limit in starting medication. There will be people who start and stop medication during their lifetime, because there is always going to be a group of people who actually, if they are in a good relationship, if they are in their perfect employment, their impairment may not be to the point where they need medication. Equally, they then may get a promotion, and that might mean lots more admin, and then they might need to go on medication again. I have lost my train of thought. But I think in terms of, there is no upper age limit. Again, like I said before, we always look at risks and benefits. Treatment can change throughout. There are, as I said before, there is a group of patients where treatment becomes less effective. We wouldn't necessarily change the dose. Sometimes it is about looking at supporting that patient with more lifestyle advice and kind of holistic approaches and managing their ADHD. Medication is an important way of managing ADHD, but it is not the only way. And I think it's really easy to forget about the holistic ways of managing ADHD.
That sort of leads on to a question about, is there any support available for patients while waiting for assessment? So I suppose that sort of leads into that in a little bit, does it, Sam? Holistic wise.
I know that we've got information on the website for people who are waiting for an assessment. In terms of waiting for treatment once they're diagnosed, we provide them with a patient information package on holistic management of ADHD, which covers advice on diet, sleep, exercise. It's got some psychological approaches that you can look at, and some other psychoeducation on ADHD management. At the moment, we don't provide talking therapies from Psychiatry UK itself. We are looking at aligning ourselves with some talking therapy services, but that's a case of watch this space.
We're just about to stand up as well, patient webinars. So similar to these webinars we do for GPs, to have webinars for patients, so when patients have been assessed, to provide them with psychoeducation and some ongoing support between assessment and treatment. And we do as well, Sam, don't we? We direct patients to apply for access to work funding. Whilst it does take some time, it is a good way for people who are eligible for that to access funding for ADHD coaching, which can be very helpful as one of the treatments for ADHD.
Definitely.
Brilliant. We've got one here around once the shared care agreement with the GP has been signed, do the patients have a regular review with the ADHD specialist, or don't they have any further specialist reviews?
We continue to see people annually whilst they remain on medication.
Can I just pick up on that, because there's a question down at the end, someone asking about our process with regard to that, saying that they have to email to remind us. We're doing a lot of work improving our processes and our pathway with regard to annual reviews at the moment. We're looking at making sure that we know all of our patients who need to have the annual review. We're doing a big campaign to drive our clinical capacity within our clinical workforce to ensure we have the right amount of appointments available for these patients, and we've done a lot of work in improving the form that a patient will complete before they have their annual review to ensure that that meeting with when they see the psychiatrist is really effective and can focus on what's needed in that appointment. So apologies if previously you've had to chase us for an annual review for your patients. We are very aware, and it's an area that we're really focusing on at the moment to ensure that we really improve our service and we automate that and make sure that patients do have those annual reviews, because we obviously recognise how important they are.
We're at 8 o'clock. I've still got a few more questions. Are you happy to take a couple more, or do you want to? Yeah, happy to do that. How long is the waiting time from the time of being referred until getting a diagnosis?
So the waiting time can be divided up into the various sections. Like I said earlier, for ADHD, it is about 6 to 9 months at the moment, but there are several other factors that may influence that. Obviously, if a patient is high risk or complex, they would be screened and come through for an early assessment. And then when the patient has had their ADHD assessment, then they're referred to our titration team. At the moment, there's about a 10-month wait for treatment, but again, it's a real primary area of focus for us across Psychiatry UK at the moment, looking at how we increase our internal capacity to have more clinicians working with us, prescribing, to reduce that waiting time for our patients, because we do recognise it is too long for our patients. So we're working hard to reduce that at present and making good progress there.
Thanks, Jo. How does Psychiatry UK avoid missing the diagnosis in patients who mask effectively?
I think it's probably impossible to get to diagnose every person who's got ADHD, but I think it's the reliance on not getting all the evidence in one meeting. We also look at the self-report, and the patient's got time to complete that. We're looking at the informant report, looking at what information supports the diagnosis there. We do an assessment. Sometimes patients submit information beforehand if they want us to read it. We look at written information. We look at the GP information, written information, any past correspondence, and the assessment itself.
Brilliant. There's a couple of questions around diagnosing ADHD in women and the different diagnostic criteria. They want to know a bit more about it. Is that, I think there was talk about that possibly being another whole webinar on its own, maybe women, because it's quite a huge topic, but I didn't know if there was something you wanted to maybe touch on that.
There's not the diagnosis, the criteria is exactly the same. So we use the DSM-5 criteria. I think it's just how women can present differently. Equally, some women present exactly as you, very similarly to the men. It's just we all present differently. Personally, I wonder if there's a little bit of a myth in the fact that women present differently, and I think it's just as we've got to see ADHD as 3 subtypes. You've got the inattentive subtype, the combined subtype, and the least common hyperactive subtype, and it's just really about doing a good quality assessment and ensuring you ask the right questions and look for the symptoms and the difficulties. But the assessment is the same, the diagnostic criteria is the same.
Brilliant, thanks, Sam. One here about fetal alcohol spectrum disorder shares similar traits as ADHD and autism. How can we ensure we're providing the right diagnosis?
I think, and I haven't looked at any research recently, but I'm pretty sure that actually it's got some of its comorbidities are neurodiversity. So I think you'd probably find that with fetal alcohol syndrome, there is an increased likelihood of having ADHD. I can be corrected on that.
Okay, we've got another one here. How do you get the private assessment treatment? What's the pathway for that?
We've got information on our website about private assessments. It's a self-referral, so the referral does not need to come from the GP. The patient can do their own referral. They then have a much more detailed form to complete. Ideally, it'd be good to get a GP summary as well. I don't know, I think we're available. I think the information is on the website, but at the moment we're not heavily promoting it. So I think at the moment we're seeing about 130 patients a month in the private setting.
But we're looking to expand and grow that. We absolutely have the capacity, and we're working very hard, with our team, to grow that private service. We've got the clinicians there who are available to do the assessment, very experienced ADHD clinicians. So yeah, we are advertising it and working with various colleagues to get the message out there that we're also providing this excellent service too.
Thanks, Jo. So this is a 60-minute assessment sufficient? It's a two-pronged question. I feel this is so quick. We also hear of non-psychiatrists diagnosing rather than psychiatrists. Does this not generate more confirmed diagnoses in such a quick turnaround if patients use the right buzzwords?
So we address that because prior to the assessment, like Sam has mentioned, a patient that we're seeing us will be completing and providing us with a lot of information. An ADHD assessment is over 100 questions worth of information that the patient has completed. So compared to maybe face-to-face NHS assessments in which all of that information needs to be covered as well in the appointment, our clinicians will have access to this information before they're seeing the patient for the 60-minute appointment, and all of our consultants need to read that, assimilate that. So then when they meet the patient for the 60 minutes, I mean, they are all very experienced consultant psychiatrists. They can focus on what they've identified in those forms and then move on to do the full assessment, including, full psychiatric assessment, also focusing on medical history and doing a full personal assessment. So yes, we do believe that because we use this pre-assessment information that we're collecting, that we can complete a comprehensive assessment in 60 minutes. Sometimes there is the need to carry up a follow-up assessment of another appointment for 30 minutes, particularly if it's a complex patient or some pre-assessment information was missing, and we support our clinicians to do that as necessary. Got to the next part of the question about non-psychiatrists diagnosing. When we have over 400 consultant psychiatrists working with us, we do have a smaller group of clinicians who are staff grade doctor psychiatrists mainly working with us, but they have consultant supervision. They've been working with us over the last year, receiving a lot of supervision and training, and I'm totally assured of the quality of the assessments that they're doing. Can't really comment on what happens in other providers, but that's something that we really feel that sets Psychiatry UK apart, the fact that we are consultant led and have so many consultants working with us.
Thanks, Jo. Do you accept patients with a previous diagnosis already on medication but lost to follow up? Do they need to go back through your own assessment process?
We do accept people with previous diagnoses. We would still we still need to see them, we still need to assess them. Obviously, that assessment might look a bit different. It depends, you know, sometimes we get the previous assessment report. Sometimes that's of good quality, sometimes that's not of a good quality, and quite often patients don't come with any information. So we always re-look at the patient. It's really important that we make our own decision as well, that they do have ADHD and that we're in support of the diagnosis. And things change, and we've got to, you know, make sure all our information is up to date, and especially their psychiatric and medical history, drug and alcohol history. So we would still offer them a full assessment.
Thanks, Sam. There wasn't any mention of guanfacine. Do we not use it? And do you find non-stimulants can work better in a combined diagnosis of ADHD and autism?
So no, we don't use guanfacine anymore. That's because it's not a first line, second line treatment. It's not supported by various you know, different guidelines. In childhood, sorry, I should say in children we do use it. In adults we don't use it. I think in terms of what works best for people with ADHD, we're still looking into. I think one of the great benefits of working in a company like Psychiatry UK is the data that we have available to us will allow us to really research these and come out with information to be able to answer questions like this. I think at the moment people have a mixed experience. We do know that people who have ADHD are very sensitive to medication. They can experience more side effects. They can also struggle with the effects of being effectively treated. So, for example, you can treat the ADHD, but that can mean that the autism then becomes louder and more dominant, and that can be really difficult. So they can be quite a complex group of patients.
Thanks, Sam. Are you able to provide a simple summary of what drop in weight, increase in BP and HR is significant on stimulants?
Dropping weight.
Increase in blood pressure and heart rate is significant. So can we do just a simple summary of what, you know, I'm assuming what they're saying is what is the lowest, you know, what is bad sort of in a drop in weight, and what is high from blood pressure, heart rate?
Again, I think we've got to look at it as a case by case basis. In terms of when we're looking at treating people, we like people's BMI to be 18.5 or over. There is a little bit of flexibility below that. If there is any concern about people's BMI or like past eating disorders, we will be closely monitoring that. And you know, any loss of weight is and considered important, especially in that group of people. Equally, people can lose weight for a variety of different reasons as well. So it's not just going to be because of the medication that we start. We're seeing an increasing group of people who are on Manjaro and similar treatments to that. So we've got to take that into account. With blood pressure and pulse, again, it's really important that they have a normal baseline before we start treatment. We're considering normal below 140/90 with a pulse rate below 100. The information in the past suggested that our medication can increase blood pressure and pulse by about 10 units. So, you know, it's nice to have that kind of leeway, although equally, you know, there is more research coming out suggesting that our medication has lesser of impact on blood pressure and pulse. But I think at the moment we still take it very seriously and we monitor closely. So we would stop people's treatment if it is above 140 over 90 and a pulse higher than 100, ensuring that we've taken, that we've given the person a chance to have an accurate reading, that it's not just a one-off. We look at the average, we ensure the person's relaxed in the right setting, try and get the right blood pressure and pulse for them.
Brilliant, thank you. We've just got a few more. Will we be opening a right to choose option for paediatrics?
Joe?
So we don't currently have right to choose for children's ADHD. We have had some contracts previously in our CAM service offering ADHD assessments and ongoing care. It's certainly something that we will be open to exploring in the future, getting an ICB contract to allow us to open up a right to choose. We do have a large number of consultants, psychiatrists who are CAM specialists, so we certainly do have the clinical expertise and capacity. And if we did go down that path and get that, we obviously would share that information with all our GPs and across the ICBs.
Thank you. We've had a comment that said that it's very reassuring to know that we are consultant led, as I've always heard rumours it's done by non-doctors. So that's positive. Do we do QB testing?
So we're currently exploring doing a pilot using the QB test. The QB test is neurocognitive testing for people with ADHD. It doesn't replace an ADHD diagnostic assessment. It can add as an additional part of an assessment. So we have met with the organisation and we're going to be looking at piloting it hopefully shortly in our ADHD service.
Thanks, Jo. There are a lot of right to choose providers now. What happens to these patients if these providers end up closing down? That's something that really you can answer, but
I imagine that somebody's got to treat them and they would be referred to a provider that hasn't closed down, hopefully us.
Yes, so if a patient was under that provider, if the GP then were to refer to Psychiatry UK, like Sam mentioned earlier, we would have a responsibility obviously to check the quality of the diagnostic reports and carry out a review with patient. And if we've had evidence that the patient has had a thorough diagnostic report, stabilised on medication, we've seen evidence of the prescription, because we have to assure safety and quality of everything that we do, then we would absolutely be more than happy to enter a shared care agreement, a new shared agreement with the patient's GP, absolutely keeping the patient at the focus of everything we do. And we don't want to have a patient's ADHD treatment and medication disrupted. So, and we do have, like I said, going back to how many clinicians we have working with us, we do have that capacity here at Psychiatry UK to be able to offer this to our patients.
Thanks, Jo. Someone's asked, do we need to monitor renal function whilst on ADHD medication, more for over 40s or with chronic kidney disease?
We don't specifically monitor it. However, there will be a subgroup of patients where it would be appropriate to keep an eye on it. Normally, with people who've got chronic renal failure, this is something that we would pass to our physical health liaison lead for their advice and support, but often it will involve corresponding with our physical health colleagues, the urologists, for their advice and working closely together.
Thanks, Sam. Would you ever offer a dose range for patients, i.e. if no better, increase by 5 to 10 milligrams, and if not, why?
We wouldn't do a dose increase range because we've got to ensure safe prescribing, that the patient's monitored. It is sometimes that people might take less of their medication. So an example could be dexamphetamine, which is your short-acting stimulant. And people may be taking it 3 times a day. They might not have a taxing day and they may just take once a day, but we would never recommend them to take more than the amount that the shared care agreement has suggested.
Brilliant, thanks, Sam. Are we actively recruiting GPs for medication titration work? And if so, where do you advertise? Where do we advertise?
We're going to be advertising that soon, just at the moment thinking through how you know the training and the support that we would have to deliver internally to the GPs joining our titration service. And where we advertise, we usually advertise our posts on our website, on LinkedIn.
Brilliant, thanks, Jo. Oh, we've just had one pop up. It's disappeared. I understand those with addictions won't be seen for ADHD diagnosis, but most of the patients have addictions due to ADHD undiagnosed. How can we go around this? Because they come back to the GP, but we can't help them much.
We would still assess patients who have a comorbidity of drugs and alcohol. Again, there are some individual cases. So, for example, if you are currently intoxicated in the assessment, that's difficult to complete an assessment. However, having a history of the disorder, struggling with a comorbid substance misuse will not stop you from being assessed. It won't stop you from being diagnosed if you have the diagnosis. It may stop or pause us treating you immediately. So it may be that some a group of these patients are asked to go back to different areas to address their substance misuse or their alcohol difficulties before we can safely start treatment. But then they can come back into the service and start treatment once they're once they're ready.
Brilliant, thanks, Sam. I've got two more questions. What is your protocol for annual recall review? At present, we have to email and remind you, meaning PUK, that an annual review is due.
I think I'd already answered that one, Bev, hadn't I?
Did you do that one? Oh,
yeah,
God,
I think
sorry.
I covered that, saying that we're doing a lot of work to improving the whole of our annual review processes and ensuring that we are inviting patients, and apologise if they'd had that experience previously.
And the final question I have here is, do you do talks for GP surgeries in terms of education for wider clinical staff at lunchtime meetings?
Not at the moment, but we certainly, something, Sharif, I'm sure that's something that you'll be taking forward, won't you, in your links and your engagement with our primary care colleagues, what we can be doing to, to support clinical staff.
I think we're also keen to continue these GP webinars and looking at different aspects of ADHD. And so, if you have topics that you think we should cover, we're very ready to take on your suggestions for the next GP webinar.
And that's the last question. Over to you, Sharif.
Yeah, thank you everyone for attending the webinar. And yeah, once again, do please reach out to me if you have any questions by Psychiatry UK, or if you have any issues that need to be resolved, or if you just want to have a chat with me. I also wanted to say that we do have a GP newsletter, so if you want to get updates from us, please do email me to be added to the mailing list. And we do try to include really useful information that's relevant for GP practices in the newsletter. And as you heard, just a personal request from us, please do add in the chat or the Q&A any suggestions you might have for topics for future webinars that you want us to run. We want to run more webinars that hopefully will be useful for you. And we have a survey that I've added in the chat, so make sure to complete that so you can receive your CPD. And yeah, just from everyone, thank you for attending, and have a good rest of your evening.